to the World Massage Conference.
Hello and welcome. This is Melanie Hayden. I will be your host for this class with Debbie Roberts, and she is going to be talking about treating the rotational athlete with the ATM system. If you're joining us for the live class, just remember to jump into the chat room located to the right of your broadcast screen. Take advantage of the opportunity to ask Debbie questions during this class and share your feedback with the other therapists from around the world as well. Just before we get started, I'd like to thank our global sponsor, Massage Envy. Massage Envy is a community of caregivers committed to helping people feel their best. They believe that therapeutic massage and customized skincare are an integral part of the well-being journey. If you share this belief, they'd like to get to know you better. Learn more at massageenvy.com/careers. And thank you to our education partner. Associated Bodywork and Massage Professionals provides an extensive array of member benefits and exceptional liability insurance. Visit abmp.com to discover why over 80,000 massage and bodywork professionals have chosen ABMP as their professional association. Thank you to our daily sponsors, Massage and Bodywork Magazine, Bonvitel, BioFreeze, and Massage Warehouse. Treating the rotational athlete with the ATM system. Debbie will share with you the principles of using the assessment, treatment, and muscle stabilization system as it pertains to sports that involve rotational movements like golf, baseball, and tennis. You'll learn to recognize common injuries acquired during these rotational sports and how those injuries occur. You'll also discover how to use a movement screen and how to examine body movement joint by joint to make your treatments more effective. I'd like to introduce our instructor, Debbie Roberts. She is a licensed massage therapist and has been practicing since 1988. She's a certified personal trainer and post-rehabilitation specialist through the National Academy of Sports Medicine, a multi-year presenter for the annual Florida State Massage Therapy Association convention, as well as teaching classes throughout the country. Debbie's work focuses on athletic assessments and treatment plans. Debbie, welcome to the World Massage Conference. It's wonderful to have you here with us today sharing this valuable information.
Melanie, it's great to be here and talking about one of my absolutely favorite topics, which is treating the rotational athlete. And welcome to all that are listening, and I'd like to just jump right in. My goal for teaching since 1995 has always been to bridge the gap between massage and fitness. I strongly feel a massage therapist needs to know what fitness knows, which is a study of movement, and fitness needs to understand what massage therapists know about fascia. I'm going to be speaking about one of my absolute passions, and that's baseball. You'll see later why. But baseball, golf, and tennis is what we treat most in my town. I created the ATM system, Assessment, Treatment, Muscle Stabilization, to help you, the therapist, understand the importance of basing your treatment modalities on the assessment. And once you create mobility, you will then need to add your stability. And my tagline, of course, if you don't assess, you're simply guessing. I'd like to invite you also to look at our massage page. I have a very unique situation in Stuart, Florida, where I treat these athletes, and you can come back to this video anytime, and that'll take you through. You get a little flavor of what all I do there at the clinic. I am certified through the Tyler's Performance Institute Medical Level 3. In 2007, I became the Medical Level 3, which is the highest level of medical golf fitness educator that you can be through them. And I did that because of working with so many amateur and pro golfers in my area. This course is taught by a team of experts. One is a sports chiropractor, Dr. Greg Rose, a cutting-edge PT, Gray Cook, and well-known golf teaching professional, Dave Phillips. The course taught you how to look at gross motions and keep breaking that down until you found the joint or joints that were being the most affected or misaligned. The course also teaches you how golf swing faults would occur based on poor joint mobility and poor joint alignment. The screen helps you, the massage therapist or trainer, to consider the most important piece in therapy, and that is finding the most non-painful dysfunctional piece before the pain has occurred. It is my intention to show you how to use this basic screen and the importance of using it when picking out your treatment modalities for the rotational athlete. Here, I'm having a bunch of fun. Here you can see me working with our local high school team. I've had the privilege of writing their preconditioning program for the past 2 years. These boys spend 21 to 29 weeks with me each year. To them, I'm known as Miss Debbie, and believe me, if they have a fascial puller problem, they come looking for me. What do I do for this, Miss Debbie? I am very lucky that my pro ball player, which I will talk about later, got me involved with them. It is truly great for these young people to experience the help that massage therapy can do. My point to sharing this with you is that we start the program off by doing the screening that I'm going to teach you to rule out possible injuries that might occur when we're looking for those non-painful dysfunctional pieces. The screen is a valuable tool to prevent injuries and rehabilitation if an injury does occur. By doing the screen, we see who is lacking mobility and who's in need of more stability. It also allows me to modify any of the exercises that I need to do based on the findings. They're a lot of fun. I have a lot of joy there. As to methods, there may be a million and then some, but principles are few. The man who grasps principles can successfully select his own methods. The man who tries methods ignoring principles is sure to have trouble. The reason I bring this up is that I see too many techniques taught and they don't teach the principle behind it. So if you look at Pilates, yoga, CrossFit, even melt method, ART, cupping, etc., those are all methods or techniques. They all have similar principles or things that they're based upon. When we look at the way we to help the body the most, there really are 3 essentials. That's optimal joint alignment with joint centration. That's meaning that the humerus is centered in the joint, the hip is centered in the joint. Respiration must be optimized. Both must be integrated into the movement patterns in order for us to help someone. Now, I found this quote in a book written by Evan Oskars in his Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. I felt so strongly about it because I watched Evan Oskars fix an SI joint without doing any manipulation, and he did it using breath and resetting the core. By understanding this principle, I've helped hundreds of clients now with SI problems. I certainly invite you to either buy his book or look up core and diaphragmatic breathing. We cannot help stabilize the spine really without it. So I'm really asking you to stop the insanity of following technique names and sit down and be more curious about why you need to decide to use that technique. Learn to assess and understand basic principles of the body. The question is, why are you choosing that technique for that person? What did you base your decision on? Even though we will be talking about the rotational athlete through this, everything I'm about to share with you can be applied to any person and any treatment plan. So here's our outline. The therapist will learn the importance of a gross movement screen for better client outcomes. Therapists will learn how to look at gross motion, active and passive range of motion, and easy treatments that are effective for some of the most common injuries to the rotational athlete. Therapists will learn how these injuries occur through poor mechanics, lack of joint motion, extensibility of tissue, and lack of stability. This is actually, this talk is actually 1 hour out of a 2-day course. So I invite you, of course, to take the longer course. So let's start off with what does baseball, golf, and tennis all have in common? They use every joint in the body. They rely on ground forces to create the rotation. They all need to produce extreme velocity. Golf can have 125 club head speed, tennis up to 150 racket speed, and baseball over 100 miles per hour in the pitch. With this, their bodies, such as the rotator cuff, have to decelerate very quickly. And that is where the injuries will usually occur, is during the deceleration phase. Everything is dependent on that joint range of motion, joint alignment at impact, the strength of the decelerating muscles, tissue extensibility, and spinal stabilization. As we'll see later, we'll talk about orthopedic norms and how pro athletes actually go beyond the orthopedic norms. They all need to have an incredible ability to separate the pelvis and the torso, to have the elastic rubber band effect for power, which happens in a split second. And I show you in detail in a slide how that happens and how you'll look for that on your massage table also. Here is my pro ball player that I got to work with. This is Scott Proctor, who's a mid-reliever for the Yankees, Atlanta Braves, Marlins, and the Dodgers. I was his off-season trainer and massage therapist during every phase of his career for 11 years. Scott was an incredible athlete. He not only threw the ball 100 miles per hour, but he had incredible stamina that came out of his work ethic. In this picture of Scott pitching, you see Scott's arm in the acceleration phase. I want you to also take a look at the batter who's getting ready to hit the ball about to be released from Scott's glove. This guy is already in a loaded rotational pelvic position, a thoracic rotation, and his neck is rotated towards Scott. So when we look at the triple rotation factor of the spine coming up in the next couple of slides, keep this guy in mind. Notice here Scott's incredible external humeral rotation of his arm without his thoracic spine leaning backwards. Both of these players need to have incredible fascial extensibility in order to coil and uncoil energy to produce 70 miles per hour bat speed and 100 miles per hour ball speed. At Dr. James Andrews' clinic, they did MRIs on healthy and non-healthy shoulders and found that 85% of the players had some form of a labial tear, which they feel must contribute to the incredible external humeral rotation of the shoulder that you see these pros get. No, this isn't my dog. This is just a representation of what happens to a pitcher's arm every time he goes into a pitch. They measured that the valgus stress on the elbow joint when a pitcher pitches is measured to a 50-pound bulldog sitting on his arm. No wonder in the last part of Scott's career he had to have a Tommy John surgery. Dr. Andrews told him his ulnar collateral ligament looked like a piece of spaghetti. He was the most used mid-reliever in the history of the New York Yankees by Joe Torre. This is a big concern in our young people playing too much. It elevates the injury rate by 5 times. Dr. Andrews, out of the alarming concern of the rise in youth ulnar collateral ligament repair, started a program called STOP. STOP stands for Sports, Trauma, and Overuse Prevention. While everybody acknowledges that injuries are expected and byproduct by a sports participation, this movement targets those injuries that could be prevented just by not allowing them to play all year. They need to have at least 4 months off. The good and bad in our profession is that we can make them feel better, but more damage can be done by not getting them to stop the sport and take a break. So if you get someone in with that elbow pain and they are playing baseball in particular, it's a good idea to refer out. I learned a long time ago it is so important to go watch the athlete perform their sport to get a better idea how they're actually using their body. Each person is different, and you cannot see this on the massage table. No matter how many times I could tell you how to fix a body part, it is how that person is working as a unit, not as an individual part. If you work on them in the field and you are getting to the root of the problem, your efforts will have what we call carryover. And then in the next few days, you should have even more carryover. This was something I learned in neuromuscular therapy, is to go out and be with the athlete. Scott came to me because he was having some anterior shoulder pain at the time, and his massage therapist wasn't evidently getting to the root of the problem. So Scott asked me for his help. And by releasing these trigger points and the tension he was experiencing subscapularis, I was able to help him. Your subscapularis muscle adds to the stability of the glenohumeral joint by helping to maintain the head of the humerus and the glenum fossa. It helps to prevent anterior displacement of the humerus. Because of a pitcher's constant tug on the anterior capsule, and the anterior capsule becomes loose, the subscapularis will be recruited to help with stabilization and keep the humerus from banging into the ceiling of the joint. Since subscapularis aids in the medial rotation of the shoulder, when it becomes shorter and shorter, this will not allow his arm to get into his key pitching positions. By releasing subscapularis, he not only no longer will have the pain, he actually has better joint centration of the humerus for the ball release, and the muscles have more action potential to fire and depress the humerus. If you'd actually like to see how far a pitcher's arm should drop below the table, go ahead and lie on the table. Your arm will probably match the table, and see how far your arm will drop past that table. Probably not far, I imagine. In a pitcher, it'll actually go 70 to almost 90 degrees past the table line. Now, this incredible feat is one of those unique things you need to know as a massage therapist, because we don't need to stretch them further into external rotation. Their anterior capsule is going to be loose already, which is why subscapularis is constantly called to action. You are going to see a loss of internal rotation of that shoulder, which is perfectly normal. In pitching, we are looking for a total of 180 degrees for humeral rotation. So if external rotation is already, we said 90 at the table, 70 past the table, which is 160 degrees, then you would not see the normal 70 degrees that orthopedic books tell you for internal rotation. This will not apply in this case. You can't assume things when you're dealing with athletes. You must know and not guess. That's what gets us in trouble. So here you see that I'm palpating subscapularis. This isn't a shoulders course, and so this is only one piece of the deceleration group. So, but I thought it was important. I want you to see how easy it is to find subscapularis on yourself. So if you'll just put your thumb in your own armpit and take your arm through internal and external rotation motion, you'll feel subscapularis jump out at you. I would like to just refer you to Dr. Travell's book on myofascial pain and dysfunction, upper half of the body, for further study. Or I have a shoulder DVD also that will help you with evaluation, or even more help for identification of the muscle. Use the trail guides for the body. And if you're live in the chat room right now, if you have had someone with a subscapularis problem, or you think you have, by all means, just jump in, and I'd be happy to answer any questions. This is how simple it can be for a massage therapist to break down almost anybody that's playing a sport, and that's to divide the body up into 4 parts. Each part affects the other parts very significantly, especially when it comes to being able to rotate. You can't have velocity and rotation without having near perfect joint alignment or joint centration in each joint. As you can see here, the pillars, the ability of the body to rotate the hips underneath the pelvis and the pelvis over the hips. Separate the pelvis from the trunk, and the trunk needs to be able to turn underneath the neck. And if you think of these 4 inverted triangles and evaluate each part separately through the gross motion test, then active and passive range of motion test, you will quickly find that the parts that are working out of sequence, you'll find them easily. This helps you find what's causing the injuries or the strains to occur. It really doesn't have to be any more complicated than that. You just have to be willing to take the time to break it down and look. So look at all the parts: the ankle, the knee, the hip. Then you look at the pelvis, the hip, the lumbar, the sacrum, and the lower rib cage, the lumbar. Then you start to look at the trunk, a separate piece, and then you have the head. And we go to even more detail a little bit later, so hang in there for that one. Your role. Well, when you deal with professional athletes, they'll have several people involved in their lives. So you are and could be a better part of that team. We're a big part of the team. If you understand the mechanisms of the sport, you're claiming to be a sports therapist too. We want to gain respect from the other team members by being able to evaluate the situation to produce successful outcomes. And I believe me, with my pro athlete, he had all of these people involved. Our goal, the goal is to help players have a repeatable and efficient pattern of movement, pain-free. So in other words, if they go out and they're inconsistent, they're going to lose their jobs. You cannot afford to guess at your work and expect a consistent outcome. I once treated Scott in Atlanta when he had to go perform, and sometimes he was performing in front of 55,000 people, and you have to be pretty efficient to allow that to happen. So here's the other slide I promised you, which helps you break down joint by joint. Keep the inverted triangles in mind. So we have the foot should be stable, and you go, really? How does that happen? When the foot strikes the ground, the foot should be so mobile that when it strikes the ground, it becomes stable. If the foot becomes stable, that allows the ankle to become mobile. If the ankle is mobile, that allows the knee to become stable. If the knee is then stable, that allows the hip to become mobile. And if the hip is mobile, that allows the lumbopelvic sacrum to become stable, so on and so forth, all the way up to C1, C2. Now let's talk about what happens when it doesn't happen that way. So my foot's overpronated. I've lost my stability. My ankle will give up its mobility. My ankle gave up its mobility, so my knee gives up its stability. My knee gives up its stability, my ankle will give up its mobility. If my hip gives up its mobility, I definitely have a lumbar problem. So most of your lumbar issues, if you just look at the hip and the way it's functioning, and I talk about that later, we're going to talk about some conditions there that are happening in the hip. But really, if you keep this in mind, the things that you're creating mobility in, every joint has a little bit of both, mobility and stability. And again, as we go further down the road, you're going to see how this comes into play. Well, here's our golfer. Look at all the ranges of motion that he has to have. When we look at this golfer, we begin to understand what it really takes for each joint to produce that coordinated pattern of movement that we talked about a couple of slides ago. If golfers actually change their orthopedic norms in the hips, if you can see my little notation over there to the side, 35 to 45 is an orthopedic norm. Well, in a golfer, they actually change that to become 60. So they actually need 60 degrees of internal and external hip rotation. You look at all of these ranges of motion that they have to obtain all at once in order to do that club head speed at about 125 miles per hour. Most sports will start with ground forces, and they have to do this to transfer the energy to the upper body. So we have to consider first the ankle's ability to invert and evert in order to turn the hip above on, and then that turns on the core. And that then engages in order to swing the club. This is an example of how we can look again at those 4 inverted triangles. Imagine those in your mind. See this guy playing golf. It is the kinetic chain reaction of parts and pieces rotating on top of each other to produce motion without a conscious thought. These guys can't think when they're out there. So here we have the skeleton. So now we get to see it without all the muscles and the shirt and all that over the top, and we can see how each piece is having to rotate and separate on top of each other. If this golfer has fascial restrictions, he's not going to be able to get into key positions. Just think, if the latissimus and its surrounding fascia is tight, the arm isn't going to be able to extend. Fascial restrictions around the scapula will also keep the arm from going into horizontal abduction. This is why it's so important to consider also Tom Meyer's work of all the fascial lines of pull and the fact that we are living in this fascial bag which needs to be released first to free up space for the body's joints to move within. To me, fascial work's the key component to all therapy, and then you can break it down into individual joints and body parts. Now, if we look at baseball, there are 3 phases of delivering the pitch, and you can see all the different ranges of motion as I go through the different phases of the pitch. The cocking phase is a period of time between the initiation of the windup and the movement at which the shoulder is in maximal external rotation. The cocking phase also includes the windup, which may be defined as the time between the initiation of movement and the moment at which the ball is released from the glove. The acceleration phase begins with the throwing shoulder in maximum external rotation and terminates with ball release. And then the follow-through phase begins at ball release and continues until the motion of throwing has ceased. The primary purpose of this phase is to comfortably decelerate the pitching arm, that's at your posterior cuff. When the front of the foot stops, it's equal to a car crash as the body and the arm whip over the leg. There's your necessary for your internal rotation of that hip. This is where the rotator cuff must be strong enough to put on the brakes. In youth players, you will even see a development of a fascial cyst in the posterior cuff from the constant deceleration. Take a close look at this player's use of the 4 inverted triangles. He needs to have the same great ranges of motion as golf in order to produce his 100-mile-per-hour pitch. Technically, you need to learn how to measure every single joint in the body. When Scott would come in, I would go through with a goniometer, and I would measure these joint ranges of motion. Some things you can eyeball, and some things you really, with a pro, you really do need to measure. And then with tennis, they need, before they get to the line to deliver the ball, they need 123 degrees of both hips to rotate to the line, shoulders 123 degrees, arm 127 degrees. And you can see their great humeral external rotation. That you increase for every 1 mile per hour for every degree you can rotate away from the ball. So we said earlier that he can take his racket speed at 150. You increase it for every degree you can turn away from the ball. So that means that when you're working with these athletes, you really need to be focusing on their hip mobility and their T-spine mobility, just even taking the T-bar along the rectus spinae and along the lamina groove. So here are principles I live by. These are principles for manual massage therapists, okay? Find 3 or more tests to correlate your findings. I consider my client history, what they're saying. Gross motion test, what it's showing me. Active range of motion, what they can actually do. Passive range of motion, what I can feel. And then a manual muscle test to find out if they've got some strength deficits. I pick my treatment based on my worst findings. I don't jump to assumptions. Like I said, 3 or more of these tests needs to correlate to your findings and your history and what they're saying. Within the treatment session, I retest them every 5 to 10 minutes. That's right. Within the treatment session, every 5 to 10 minutes to find out if I'm on the right path. Because if you are, you will start producing a result instantaneously. This should not take 6 visits for it to happen if you just follow this recipe of assessment, treatment, muscle stabilization. Let's go to the next one. So our gross motion test. If we look at our gross motion test, which in this case I'm giving you an example of a deep squat, it tells you all 10 things. Ankle joint mobility, the gastroc soleus tissue extensibility, If they're underactive or overactive of the psoas, that's how they hold their trunk. In other words, you look at the force coupling of the hips. You'll see if they transfer right or left, if they shift, if they cave. You'll see on the next slide. Well, I'll show you that. I'll get to show you what that really looks like on the loss of gluteal strength. If they have an S posture or C posture in the thoracic or lumbar spine, are they limited in thoracic extension? That would be if their arms were up overhead. How tight the lat is, the glenohumeral joint, if they're having an issue. If they can't get that arm up, we know that it's either got to be in the joint itself or the latissimus is being tight. So how do you do this in a treatment room? That you're all wondering, scratching your heads. Well, all I do, if you will watch them sit down on a chair, just watch them sit down, you can take a quick evaluation of everything I just listed here. You'll see if they shift right or left. You'll see if they start to cave. You'll see if their knee changes. You'll see if their foot changes. It's just really a matter of looking at them sit down in a chair. This is one of the most powerful tests you can master. This test leads you down the road to what do you need to break down next. And I want to tell you, I performed all of the range of motion tests, all of them, on everybody until I started to understand how I could find just 3 pieces. So practice, grab another massage therapist, grab a family member, good client, just practice so that you understand what every joint should be offering and why this looks so, just how it's offering. So let's look at this next one. Here I am. I'm showing you a very failed gross motion test. You can see I'm looking stiff. I have the inability to keep my knees in alignment, the need for my body to cave over the weight over the first toe. If that happens, it tells you I could have a hip either mobility or stability issue. It's your job to break it down further by doing both passive and active range of motion tests from here. This is your gross motion. You get to look at everybody at once, and then you've got to go break it down and then follow that with manual muscle testing. Right now, if you wanted to, but certainly afterwards, assess yourself in front of a mirror and see if you shift. See if you have trouble getting down. See if your knees are staying in alignment. The only way to get better at assessing is to do it. So from here, this gross motion test, one of the first ones that you want to do is break down we call it a soleus test, but it tells us also about how well the talus, the tarsal subtalar joint is working. So soleus test is a gravity test to tell you either that there might be a subtalar issue or a fascial issue with your gastroc and soleus chain. When you compare them, you want to compare them bilaterally. If one doesn't move as well as the other, well, you can start to see if it correlates with your health history and the complaint and match up with the problem with their ability to transfer energy. Because what they're going to do, they're going to complain to you that they don't feel like they can stabilize during the swing. Now, this is talking about golf in particular. They'll want to come out of their swing too quick. Maybe this person's complaining of knee pain, or maybe they're presenting with piriformis syndrome. This test still is appropriate because it starts to tell you from the bottom to go to the top. This helps you correct the beginning of your kinetic fascial chain. So again, I invite you to go ahead and put yourself in this position, lay a tape measure out from the big toe, 4 inches, and compare your two sides and see if you have a gross bilateral difference, and get another massage therapist to work on your soleus and gastroc and see if you improve, because you should. The next test is should correlate with your subtalar test or your soleus test. The inversion-eversion test will probably correlate with that, and the side that is tighter will have problems stabilizing during the test and will fatigue sooner. In gait, when the foot moves easily through inversion-eversion, it sends a signal up to the top of the hips to turn on properly. When this doesn't happen, the largest hip rotator, piriformis, may start to produce reflective tightness, trying to help the other hip rotators do their job. the ability for the foot to go through inversion and eversion is incredibly important for the entire force coupling of the hip to stabilize the femur. So again, I invite you, go ahead and stand up right now and do the test, evaluate your ankles and the ability to recover through motion, and you will see the difference between the right and left side. You need to do at least 10 repetitions. In golf in particular, well, also in anyone that has to transfer their weight, if they're not doing that properly and they already are telling you that, you will see that in this test. It shows up because they can't invert and evert the way they're supposed to. Here you have the example of what happens. This person's stuck in pronation, so they aren't coming out of that inversion. They're staying everted. So a Morton's foot or overpronation can cause excessive medial rotation and adduction of the thigh during running and walking, causing the piriformis to be overworked as it attempts to counteract medial rotation. And this certainly leads to the hypertonicity. One of the most common complaints of golfers or tennis players that we see that are not at the pro level is piriformis syndrome. I can tell you from experience they all fail the squat test. Their ankles are incredibly tight. One of your steps in therapy would to be free up the fascia and tissues on the medial side of the leg to help these muscles activate when they should. And you may have to go a step further if you really want to help them out, which I had to once with a girlfriend of mine that was having piriformis syndrome and she wanted to go run a marathon, is that they may also need to go see a podiatrist and get an orthotic prescribed to help them get out of the immediate pain. That is the possibility. So here you see that I'm feeling for that movement of the subtalar joint. My pressure, by the way, is less than 10%. I cup the foot to take the tension out of the muscles and look for the foot to just flop in my hand. It should just move very easily if it's not if the subtalar isn't part of the issue. Now you're going to see me start into some treatment for that lower extremity. And here I'm using a gua sha tool, cost me a whopping $2.50, to help break up very surface nodules in the fascia. This is very effective if you use it properly and do not go deep. But I would love to. I use it all the time to save my hands. I don't use this like an acupuncture does when they're doing gua sha that leave that really big red mark. I just use it surface. I feel for the nodules. I find the right angle to break up the adhesions without leaving the marks. And a quote from Ida Roth, it's not how deep you go, but how you go deep. Just keep that in mind. I really am a very subtle massage therapist anymore. I find that it's just easier on the body, easier on them, and you don't really have to go that deep with some of these tools like this next one that I'm showing you. Here I'm using a silicone cup to free up the fascia. I've been doing cupping since 2006 when my pro ball player got me into it. I find using the cupping with a negative pressure helps free up the tissue that is otherwise difficult to accomplish through just hands-on. When the fascia is damaged or in constant state of misalignment, it becomes thick, stiff, and inflexible. This can result in pain and stiffness and limit your range of motion, and in this case, the ankle. The areas where the fascia has become stiff and inflexible are called those adhesions. The adhesions are thought to be glue-like. Instead of being smooth, thin, and slippery, the damaged fascia becomes thick and sticky. So instead of allowing the muscles to glide easily against each other, which they have to do to fire, the adhesions cause more difficult range of motion, muscles to become restricted. Movement's more difficult, range of motion of course, in this case, your ankle decreases. So, and then in this case, you're trying to help the person invert the foot or pick the medial arch up better by releasing these tissues to allow them to glide and do the job that they were meant to do. Here, you see me treating, you see a picture of the treatment. After I've properly addressed the fascia, then I start with the hands-on piece because I want to release the fascial bag first. Here, you want your thumb or hands to glide along the bone without using excessive force because you don't want to compress the posterior tibial nerve. Tarsal tunnel syndrome is a compression of squeezing on that posterior tibial nerve that produces, and you don't want to, and that's what you're trying to avoid. Tibial posterior is the most anterior, followed by flexor digitorum, and then the tibial artery, and then the tibial nerve, and then flexor hallucis. So again, I find it so much easier to release those surface tissues first, and then you aren't having any worry about compression of any nerves. And you get so much more freedom of motion for the ankle joint as well. Here you see me, I bend the knee up. This allows you to get the gastroc out of your way, and you can get underneath to treat soleus. I'm doing some simple compressions here, but what I do is I also hold onto the tissue, and I ask the person to go through dorsiflexion, plantar flexion, and dorsiflexion. I'm using some simple pin and stretch here also. It's really effective, I find. In addition to this, at the same time when this leg is up, I'll actually grab a warm stone to help the viscosity of the tissues. So I use a lot of heat treatment, alternating back and forth between the negative pressure, the little bar release, and the direct hands-on approach. I just find it really is truly effective. I want to quickly remind you how important the flexibility of the foot needs to be along all the articulating surfaces so that you can see, I put this slide up here, that you see all those little surfaces have to be able to be flexible and articulate onto each other. If you think back of the slide that we had before of the foot stuck in pronation, you can see how they would be riding on that navicular bone. And it's going to take some real abuse as well. And also you would see if that foot is stuck in that pronation, that calcaneus is everted out. So your tennis player is going to present to you with an Achilles tendon issue. Just remember that each one of these bones were designed to glide onto each other. So now the next few slides, I'm going to show you what I would do in particular for each one of these rays. Each one of the metatarsals, you're going to hear me say rays. They consider each one, them 1 through 5, as rays. Here I'm just demonstrating wringing out of the foot, back and forth, working on some mobilization of the foot. I actually divide the foot up into thirds, the ball and foot, midfoot, and calcaneus. I want you to understand, though, none of this should be aggressive. The mechanoreceptors respond so much better to subtle motions rather than big aggressive ones. We're trying to produce mobility here, and you never know what's going on without an x-ray, how much calcium deposit someone might have. It's important, you see me here, it's important for the first metatarsal to have 90 degrees of dorsiflexion in order to toe off in gait and to stabilize through other motions. They will actually put a little stabilizer there if someone's lost some of that dorsiflexion. So what I do is like I said before, I just take the foot and I will try to mobilize between my thumb and my finger and just bring that up and down in an up and down motion and gently mobilize each ray. And once again, this slide's just to remind you of what we just talked about. Just make sure they have the ability to spread. If you think of the 5-finger shoes, by the way, the 5-finger shoes were designed to help that spread of those rays and those metatarsals. And so you're doing that manually for that person. Here I'm trying to free up the band of retinaculum over the tarsal joint. And then I'll go on further up to work on tibialis. When you have a positive test where the gastroc and soleus are tight, refer back to the test that we did before, and the foot is in an improper position, tibialis has been trying this whole time to help lift up those toes. But over time, he gets wore out. He gets short and tight, And again, he can't activate properly to lift the toes up. So it'll be your job to help tibialis out as well to reset part of the kinetic chain. Follow the same treatment sequence, whether it is in the front that you're working on, the back of the body you're working on, or either side of the ankle. Number 1, break up adhesions. Number 2, lift up the fascia. Number 3, get in there and palpate. Number 4, do some pin and stretch. Number 5, reset with some isometrics. And again, I'm showing you the back side of what I do to those rays, just my finger position. I just work that whole foot. Once you've done this, then you might want to go into stretching the foot or teaching the person what they need to do. Here I have a rope looped around my foot. To stretch these muscles, the inverters of the foot, you've got to evert the foot out, doing self-myofascial release with the rope looped around. So you could also do this manually, by the way, for the client, and we teach this in my flexibility course. And here we go on to stretching the everters. So in order to do that, you can see that I'm pulling on the inside of the rope to stretch the outside of the foot. And next, you see my assistant, which is my husband. We're doing resisted plantar flexion here. So I could either use this as the muscle stabilization part, kind of the reset, talking to the mechanoreceptors, or I could have used this as my manual muscle test as well to find out if they've lost some strength. Because after your body work and you go back and do manual muscle testing, they should have gained strength. That's why it's so important to go through the ATM all the way through, what did I say before, every 5 to 10 minutes within your treatment session, okay? Next, you see us doing resisted dorsiflexion. So every movement that the ankle is going to make, we are going to do resisted, some form of resistance. The resistance, you can go up to 25%. So I can use it as a manual muscle test, or I could use it as a reset as well. Here you see us resisting inversion. And again, same thing. I'm going to use it for reset or a manual muscle test. Have they lost? This is really important. You guys should really try this on a lot of your clients, because if you went in there and tested inversion, I can guarantee you those tissues are so tight, which I just showed you how to release those tissues. They're so tight that they've lost the ability for that to fire even under just a manual muscle test. So you could only imagine what happens in gait if they can't do that. So then we have, again, resisted eversion. So going all the way around the ankle, this not only helps rehab an ankle, by the way, this is one of the rehab protocols I would use for any ankle, but this also helps reset the kinetic chain so that they can start off those ground forces. So the next slide is going to show you what I mean by that ground forces and how that goes up the chain. Now we're going to start also in talking about some familiar things like piriformis syndrome and some trochanteric bursitis. So here we see that the pelvis is the friend, right? He's the friend to the upper body and the lower body. He allows us to run, jump, sprint, dance, climb, kick, stand, but he also transfers energy to the upper body to allow us to throw, swing a golf club, tennis racket, grass tools, carry things. Let's imagine he's our friend, but our friend gets arthritis. So let's say our friend gets arthritis in the hip, and I lose just 5 to 10 degrees. So let's think of our golfer, our tennis player. I lose 5 to 10 degrees of internal rotation, which is paramount to the golfer and also tennis and the baseball. I will have to make up that difference with my upper body. And how I make up that difference is that my upper body will have to decelerate so much harder, 10% harder. So that means my posterior cuff takes the brunt. And if I wear out that posterior cuff or I wear out my cuff, my humerus is going to bang into the ceiling of the joint. And if it does that, then that's how I get a supraspinatus tear. So it's so important. Our pelvis is an important factor because it allows us to transfer 50% come from the lower body to go 50% to the upper body. If we look at this next slide, this shows you there has to be optimal length tension relationships of the lumbopelvic hip complex, the force couples that create a neutral pelvic alignment. The pelvis is in neutral alignment when the anterior superior iliac spine and the pubic symphysis are in the same vertical plane. As you see here, the pelvis is in an anterior tilt with the ASIS anterior to the pubic symphysis, and the pelvis is considered in a posterior tilt when the anterior superior iliac spine falls posterior to the pubic symphysis. So our goal, of course, for the client is to get them in a neutral position. If you look at this anterior rotation of the pelvis, this is close packing. This is close packing our pelvis, our top of our femur, and that's how we wear out that femur, is because of this anterior rotation. Here, we could do a static evaluation. We could put on, see if it's level, if our thumbs match up at the PSISs. But I'd like to just guide you over to looking at the muscular structure. If you look right here where the right hip is pink, it's showing that the right hip is weak. So who has to overstabilize? It's the QL. And then we start to get that lateral tilt. So it's a chain reaction because if you go back to what I taught you before, it starts off with there's tightness in the gastroc, which throws off the whole kinetic chain because that foot must have not been able to go to inversion, eversion. So my hip doesn't get turned on. So my QL decides to overstabilize. And as you can see, if I follow it all the way up, then I'm going to end up with a shoulder issue. That's how it can happen. But my pelvis is key to transferring the energy from the upper to the lower. Here's a very, very, very important test, which is called the Faber test, flexion, abduction, external rotation of the hip. I am presenting with you right here in this slide a failed Faber test. The leg should have flattened out. So if you find pain in the front of the hip joint, you are looking at hip joint pathology, degenerative joint disease, anterior capsule tightness, or even a possible labral tear if they show up on your table. What I do is I do a bilateral comparison. If the pain is felt in the back, when they cross that leg over, it's felt in the back, over the lumbar spine or the SI joint, then you have to suspect a limited hip mobility, and that's creating, of course, a lumbopelvic instability. So this is a really powerful test to do on all your golfers. They're presenting with the piriformis syndrome because it all correlates around that. If you already have them on the table, a simple test you can do is to have the client do an active hip extension. When you step back, they should be able to clear the table by 30 degrees, which is normal. In your high-level sports, they actually clear the table 60 degrees. So this test is also telling you that if they only clear, in other words, there's the clearance between the table and how high the knee lifts. If there's only 10 degrees or less, they have degenerative joint disease. And so the next couple slides, you're going to see me look at internal rotation of the hip. Those two tests will probably correlate, and that is why you're starting to have they're starting to have lumbar pain, or they're starting to have hip bursitis. So we look at this guy, we can almost bet he's going to fail his squat test. The stiffer someone is, they're 3 to 5 times more likely to have the injuries that you're seeing show up on your table, which is Achilles tendon, Achilles tendonitis, our knee, our hip bursitis, and then, of course, it goes up into lumbar pain. And this is an example from the golf world of what a player looks like who has a tight hip capsule. So if you look at the first slide where his butt is along this line, in the second one, as he's went through his backswing through into the slot going into this follow-through, you see how far he's moved away from the line. He shouldn't have done that. Because of his hip tightness, and the left hip in this right-handed golfer is paramount to it should have at least the orthopedic norm, which is 45 degrees of internal rotation. Remember, the athletic norm is 60 degrees of internal rotation. If he doesn't have that, what happens is he stands up in his swing. He can't stay down because his pelvis cannot rotate over the top of the hip. He can't stay into his beginning posture, his golf posture. A golfer will say to you, I'm losing my golf posture. I don't know why. I'm standing up too early. This is their verbiage for calling it early extension. You as a massage therapist need to know that it's ankle inversion, eversion, and it's hip internal and external rotation that you need to go after to help this player, basically. So here we have a picture of the hip trochanteric bursitis. I once helped a golfer out, and she had swollen both hips so bad because she was such a long-distance hitter that she had inflamed both of these internal hip bursts so much that the doctor actually said he thought that they were going to rupture. But I'm going to talk about what you can help, and that's trochanteric bursitis. It results from when the bursa over the greater trochanter of the femur is irritated by repetitive stresses encountered during the impact. And it can happen over running, by the way, also, so that's our tennis player. There will be a limited amount of iliotibial band movement, and it's commonly associated with the friction of the overlying the iliotibial band. So what I do right here is, and you're going to see this later, is in order to help this IT band, I treat the whole IT band and lift it up with cupping. Here you can see that the TFL acts as a pseudotrochanteric bursitis. And again, it's a simple fix because it's become too tight. So if you will actually take the cup, break up the nodules that we talked about, use some heat, keep repeating this. Don't stay on one treatment the whole time. Keep going through the treatment like it's a treatment plan, one right after the other. You'll start to loosen up these tissues. So these bands can get so tight that it actually mimics, it would have mimicked a true trochanteric bursitis. Here you see the Aubert test, which is testing for the iliotibial band tightness. The bottom leg's flexed to 90, abduct the test leg to 90, allow the knee to slightly flex, do not close the knee, this puts too much tension through the quadricep. Look for the test knee to drop to the table, and you can monitor also the pelvis. You don't want the pelvis to move as well. So the knee can be a little more open than what we have the knee right here. Here we're starting to just begin it. And that knee should have dropped to the table. When it doesn't, it tells you how tight that iliotibial band is. Here, the Thomas test, one knee, this is simple. You have the person sit on the edge of the table. They draw their knee up to chest. You have them fall back, and you stand back and you take a look. If that knee stays up off the table, their psoas is tight, their quadricep is tight, their iliacus is tight, and if their foot is rotated out, their TFL is tight. So again, this starts to lead you down the treatment path. Now, there's a problem. Most massage therapists think that all psoases are tight. Well, they're tight but they could be turned off. They're not stabilizing. So it's also important to test to find out. The test before that you saw, this is your length test. This is your strength test. They need to be able to stand there and bring their knee up above 90. And I can tell you, a lot of times, these people that present with trochanteric bursitis and their psoas is not stabilizing. So you have to know the difference between mobility and stability. And again, I'm giving you the orthopedic norms. In golf, for internal rotation of that hip, we need at least 55 degrees. Baseball, we need at least 60. And in tennis, we also need at least 60 degrees. Simple way to do that, once they're lying on the table, I always tell the client I'm going to be looking to compare your hips bilaterally. I look to see if they're equal. It's pretty simple, even without putting a goniometer on. One will flop out more than the other, but I do want to caution you, it doesn't always mean that something's tight. If one flops out more than the other, it can mean that there's instability, not necessarily that it's tight. So you have to keep learning how to break things down to understand when it has a mobility or a stability problem. And when I teach the other part, the excessive movement in the pelvis in the classroom. To do the manual muscle test, you see me starting in about 30 degrees. To actually test the whole force coupling around the hip, you allow the test to go through 30 degrees resistance, that's your 25% resistance, 60 degrees, 90, and 120. And this is your marker. While you're doing therapy, this should get stronger if you're doing your job. So this is giving you a picture of how you could go in. You can pick up the hip and mobilize a little bit of that hip and get some more movement in there. But again, big, big, big word of caution. Any joint can have calcium spurs. And anytime you move those tissues over those spurs, which are like barnacles, you can do micro tearing or worse. This is why you can never go wrong by loosening up the tissue, like I explained to you earlier, to help the muscles glide and have a better action potential rather than going after great mobilization. So I'm showing you this picture because I take my cup throughout everything. All of these muscles have a fascial component they need to glide upon. If you look here all the way down to the fibula, I've got to release the TFL, the whole IT band, the gluteals, the quadricep in front of the IT band, the quadricep in back of the IT band, the hamstring. All of this has to be released, and then I have to go retest it to find out if I've taken the pressure off of that bursa for that trochanteric bursitis. And the next slide just shows you again what it would look like. You can certainly see that if that hip becomes too tight, what it's going to do to the sacral position, so that if that sacrum's off, I'm not going to have that friendly pelvis helping me transfer that energy from my lower body to my upper body. So just free everything up. Instead of digging an elbow on piriformis, which could damage your sciatic nerve, just pick the tissues up over that, and then the piriformis will have the ability to glide and do his job better by creating more glide to tissues. And again, showing you the TFL, you can be particular with your palpation skills, but you need to clear the whole fascial bag to really do this person any good whatsoever. And then if you go to the iliotibial band, the last but not least, you could do this manually for the client. Here you see me using a rope. I would have manually abducted their leg against my hand for 6 seconds, had them take a big, deep breath, inhale, and on the exhale, I would have helped that leg come across. Now, this is helping that Aubert test that we talked about earlier. So all of this, when I go back and retest the Aubert test, I should have made a difference with that test. If I haven't, I don't want to wait till the end of the treatment plan to figure out that I did not make that difference. So I encourage you, please, to do that several times within your treatment. So here's in closing, I want you to learn how to build your case. Match treatment with assessment. Match treatment with condition and assessment. Learn to recognize dysfunction based on your assessment. And is there carryover? Is there carryover? When you call them the next day, are they back in pain? Because if you were on the right treatment path, they shouldn't have been in pain. So there should be immediate carryover. Go out with them. There should be carryover. Go for principles, not techniques. Principles will take you so much further than techniques. If you don't know how to assess and you don't know joint ranges of motions, we did create this DVD, 50 Ways to Assess and Not Guess, and every slide stops, and if you don't get those ranges of motion, the next slide that comes through, it does tell you what possible muscles are tight. So I invite you to click on to the link, and I have an upper and a lower example, but there are 50 of them in there for you to take a look at. So if you have any questions, I'm certainly here to answer them. I want to invite you all of you to come to any of my assessment seminars. We have something on every body part out there. This is my beautiful Nala and Simba. And visit me at www.debbierobertsseminars.com. And for any more class information or some DVDs to help out your educational process. It's been such a pleasure to teach for you, and again, if there's any questions, I would certainly be happy to answer them.
Debbie, fabulous presentation. Thank you so much. Really, really detailed. I know that was a lot of information. That
was a lot of information.
This is one of those drinking from a fire hose classes where I think people will, and again, what's great about online classes is that people will have the opportunity to go back, to take a look, to stop the video, to move back, to listen again, and to take lots of notes.
You know, that's what I was thinking the whole time, Melanie, is how awesome this is, because I went into a lot of detail, but you don't have to absorb it all at once. You can go back, you can review it as much as you need to.
Exactly. And I think, like from my practice anyways, I don't treat athletes specifically, but I do treat a lot of people who, especially are sort of the weekend warriors. They might go out and in the summer here, they're going to be playing baseball and soccer, and they're going to be doing golf and things like that. So they may not have this degree of complexity in their sports like you're treating, professional athletes, but we're still going to see some of that showing up in our practices.
Well, this was talking a little bit about my professional, but goodness knows I'm in Florida where they're all retired. So my professional athletes are ex-professional athletes, and so they have everything known to man going wrong with them. But they're ex-professional athletes, and these assessments I use. It doesn't matter if it was a car accident. It doesn't matter if it just really doesn't matter. These assessments I use in every single case.
Yeah. And you can certainly see how, with the images that you shared that showed the degree of rotation on each area of the body. That's so fascinating. And it really, it's kind of mind-boggling. We all know everything is connected to everything, but that just really drives that home with those images.
Yeah, and then again, I think by dividing it up into 4 parts, it's easy for the massage therapist to go, oh, okay, well, this would be too tight in this area, which is affecting this area, so now let me do that, blah, 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 blah. Even if it takes them at least 4 sessions to accomplish it, anyway, I feel like it gives them an easy, simple way to, dissect it, evaluate it, and digest it.
Mm-hmm. Exactly. Well, Debbie, thanks again so much. And again, I just want to encourage people to reach out to Debbie and connect with her. If you have questions, if you're excited about learning more about this, Debbie teaches around the U.S. And I'm sure she would be willing to go to pretty much any other country if you can put a group together. So make sure you stay in touch with Debbie and learn more.
Thanks again.
Great. And just before we go, I would like to thank our sponsors. Thank you to our global sponsor, Massage Envy. As a Massage Envy therapist, you put your heart and soul into helping others feel their best. You deserve a career that nurtures you as a person, an artist, and a professional. Visit massageenvy.com/careers to find a career that cares for you. Massage Envy franchise locations are independently owned and operated and are the sole employers for all positions. And thank you to our education partner, Associated Bodywork and Massage Professionals. They provide an extensive array of member benefits and exceptional liability insurance. Visit them at abmp.com to discover why over 80,000 massage and bodywork professionals have chosen ABMP as their professional association. Thank you to our daily sponsors, Massage and Bodywork Magazine, Bombitell, BioFreeze, and Massage Warehouse. And thanks again so much to Debbie Roberts for taking the time today to spend with us.